Hello, ladies and gentlemen, and welcome to this LHSN webinar titled Stemming the Superbug Tide, Just a Few Dollars More, looking at the new OECD report on AMR. My name is Mary Helen Pombo, and as a fellow at the Center for Health Policy at Imperial College London, I lead on the Leading Health Systems Network program. To briefly provide some context on the network, the LHSN is a collaborative network of healthcare leaders and organizations working to improve health service delivery. Based here at Imperial College London and working in partnership with the World Innovation Summit for Health. Today we have three outstanding experts joining us from the OECD to provide an in-depth review of their latest AMR report, released just last month in November 2018. Now, this webinar complements an ongoing theme in our series, one which seeks to understand which antimicrobial resistance and stewardship interventions are most cost-effective. Our earlier talk this year on how to develop an economic evaluation framework for hospital antimicrobial stewardship programs provided a micro-level answer to this question. Well, now today's talk will allow us to step back and learn from a macro-level and international perspective on the human health sector as a whole. We're especially pleased to be hosting this discussion as the country-specific results of this report currently stand as the most comprehensive and detailed assessment undertaken on the health and economic effects of AMR. Before getting into more content, just a word on social media. We welcome you to join today's conversation online via LinkedIn and Twitter. Our handle and hashtag for this event are available on the presentation. We also invite you to introduce yourselves to other listeners and send over any questions via the chat box function during the presentation. With that, I will introduce our three excellent speakers. Dr. Michele Faccini is Senior Economist in the Health Division of the OECD in Paris, where he leads the public health work within the division. Michele also holds an adjunct professor position in applied health economics at the University of Siena School of Public Health in Italy. He has also served as an advisor to governments and international agencies, including the WHO, the International Agency for Research on Cancer, the European Commission, and the World Bank. Michele holds a master's degree in health policy, planning, and financing from the London School of Economics and the London School of Hygiene and Tropical Medicine. He also brings a PhD from Imperial College London. Dr. Driz Wakim is also joining us from the Health Division at the OECD as an epidemiologist and health policy analyst. Before joining the organization, Driz has held various research and teaching positions at the University of Melbourne Centre for Epidemiology and Biostatistics. He brings a PhD in epidemiology from the University of Melbourne and a master's in public health from the University Claude Bernard Lyon 1. Lastly, we have Dr. Tiago Cravo Oliveira, also a policy analyst at the OECD's Health Division. In this capacity, Tiago uses modeling and simulations to inform sound policies around antimicrobial resistance and social protection for long-term care. Before joining the OECD, Tiago held a number of research positions at Imperial Business Analytics with KPMG in London and at the Institute for Health Metrics and Evaluation in Seattle. He brings a Master's of Science in Biomedical Engineering from the Technical University of Lisbon and a PhD in Health Management from Imperial College London. Michele, Driz, and Tiago, it is excellent to have you here with us. Michele, I'll turn over the audience over to you.
Thank you very much, Mary Helen. Hello to everybody, those that have joined us for today. My name is Michele Cecchini, and I lead the work on public health here in the OECD Health Division. And as said by Mary Helen, I have with me the other main person that has been working on this OECD report. Now, in the next 35 minutes or so, we are going to give you an overview of the key findings that were produced as part of this report. But let me give you a little bit, in a couple of slides, an introduction of OECD work on public health, and in particular on the work on antimicrobial resistance. The OECD program of work on the economics of public health started and was conceived in 2004 during the ministerial meeting that was held at the time, and in particular was strongly called for by Julio Frank, that at that time was Minister of Health in Mexico, and then moved to other positions, including the Dean of the School of Public Health at Harvard. So at the OECD, that as you may know is essentially an economic organization. So our work focus on economic aspects related to public health. We have two main objectives. The first one is to make the economic case to invest in public health. And the second is to identify cost-effective action and support the implementation of this action by member countries. In practical terms, this means that we respond to 5 key questions that policymakers need to know to implement effective and cost-effective policy options to tackle major public health challenges at the global level. Does a public health policy improve the health of a population? What is the impact on health expenditure and economy? Does this policy improve health inequality? Is this a cost-effective action? Does the return of investment support the implementation of these policies? Finally, when will desired effect show up after the implementation of this policy? Now, that's also exactly the same type of questions and issues that we address in our program on public health. And in particular, we cover 3 main areas on antimicrobial resistance. We work to ensure sustainable research and development. The focus of today will be more on the economic analysis of scenario and the policy option, and identification and analysis of best practices. And we do this really to feed the global debate and the policymaker process on AMR. Results of our work normally feed the G7, G20 debate on various public health issues, and also the work on antimicrobial resistance will feed the forthcoming meeting of the EU president, the Romanian presidency, which will have a strong focus on antimicrobial resistance and action that countries can put in place. Now, Stemming the Superbug Tide, just a few dollars more, carries out this type of analysis into all different domains, and I'm going to stop here. Just let me tell you that our focus is again on economic cost and of inaction. We looked at packages of policies and at the effectiveness of single policies, and we have a very comprehensive geographical scope for up to 52 countries. Having said so, I leave the floor to the second speaker, Tiago Cravo Oliveira, that will guide us through some of the results. Thank you very much for your attention.
Hello, good afternoon. As Michele said, I will take over and introduce the analytical part of the study. So it really starts with the question, if we want to predict the health and economic burden of antimicrobial resistance, we need to understand what will be the future resistance proportions, so the proportion of infections that will be resistant and the number of infections that will be resistant. This particular part of the work looks at resistance proportions. So the percentage of infections that are found to be resistant. And we do this for 8 antibiotic bacterium pairs. We selected these according to data availability, but also policy relevance. And you can see there the WHO list of priority pathogens. And we do it for 52 countries, which essentially amount to the OECD, the European Economic Area, and the G20. So just to give you an overview of the methodology and the approach, we start, of course, with the data. So the data for antimicrobial use and resistance come from a set of visualizations called Resistance Map, which is created by the Center for Disease Dynamics, Economics, and Prevention, which provides a comparable or quasi-comparable national level yearly antibiotic resistance and consumption globally. The coverage is not perfect, but it has a lot of countries and it's fairly recent, and it acted as a way for us to update some of the analysis that have been done in the past. For example, from the AMR review or the World Bank, which relied mostly on scenarios. Our analysis relies on actual data. Because these data actually have a lot of gaps, so there's a lot of missing data, we also collect data on covariates. And these come from various sources, from our own databases, OECD.stat, but also from the World Bank, the USDA, FAO, etc. And we use these in the first step of the data preparation to run multiple imputations. So we basically have a best guess based on covariates, all the information that the data provides us. We make a best guess as to what would be the resistance proportion in a specific country for a specific year if that data is missing. And because there's uncertainty in the step, you'll see there in the circles that the number 150, that means we run 150 times this multiple imputation for each value. So we end up with 150 data sets, possible data sets. Now, we have a complete data set at this point, a complete historical data set. We move on to the forecasting. To do this, we also use covariates to inform the forecasts. We take advantage of available data as much as possible, so we have their external forecasts from various sources. And as much as possible, we introduce uncertainty in those as well. So, for example, antimicrobial use was forecasted in-house because we couldn't find global forecasts. So you see 150 there. And then what we do is we end up with 150 data sets for historical data, let's say, and for future data in terms of covariates. And we split those randomly and evenly between 3 methods. This is to account for uncertainty in model selection. So we are unsure whether a linear regression would be the best model. So we apply 3 different models. One of them is a random forest. So it adds a nonlinear aspect to it. And then we have a simple trend using exponential smoothing. At the end, we end with rates of resistance proportions for 8 pathogen antibiotic pairs for 52 countries from 2000 to 2030. And we have 150 values. And we, as I said, we do this for resistance proportions only. We do not estimate incidence. So what are the results? Resistance proportions will grow moderately. Now there's a but and it's highlighted, and that means that's actually to say that there is a lot of heterogeneity between countries, but also within countries between antibiotic bacterium combinations. It's really, if you look at the publication, you will see that there's a lot of heterogeneity, a lot of variation. And it's a bit interesting, actually, and puzzling, some of this variation. You can see there that the lowest countries, the countries with the lowest average resistance proportions of around 5% are Northern European countries. And then on the other extreme, you have countries like Greece, Korea, Turkey, and the OECD. If you move outside the OECD, you have countries like China, Russia, the Russian Federation, and India, which have rates closer to 40 and 50, which is about 8 to 10 times the lowest rates, which really shows that maybe there's a lot of scope for action, for policy interventions. And members of the EU and OECD have rates of around 18% overall countries and antibiotic bacterium combinations, and this compares to about 30% in 2015 for the G20. The next slide. One of the big concerns from what's coming out is that the rates of resistance proportions are going, the growth seems to be slowing. So if you look at 2005 compared to 2015, and then 2015 to 2030, the rates seem to be slowing down. But this actually masks growth rates in 2nd and 3rd line treatments that are actually increasing much faster. And you can see that, for example, in G20, but also in the EU, 3rd line treatments are growing now at the fastest rate compared to 2nd and 1st line. This is really worrisome because after, for example, the 3rd line treatment in our analysis is carbapenems. After carbapenems, there's really only less effective treatments and more problematic, like colistin and combination therapies. And in some countries, even these are becoming not available because of resistance as well, for example, in Greece and Italy. So this is really concerning. Now, where is all this heterogeneity and variation, and why do we see these numbers? So we ran a few analyses. You can see here a diagram of many possible factors influencing emergence and spread of AMR. And unfortunately, if we were to analyze this statistically, we would need comprehensive, comparable, and reliable data on all these, but that's really missing. There is no such data. And we see also in certain analytical studies that there's evidence of nonlinear relationships and intricate associations between all these variables. So statistically, if we go to the next slide, what we've shown in the publication is simple univariate analyses. And the point was not to say that you can understand the drivers of resistance using scatter plots. The point was to show that different factors will account for the evolution of resistance differently for depending on the antibiotic bacterium combination, depending on the country, and they will interact differently as well. And so when we run multivariate regressions, which we did and ended up not including in the publication, you will see a very limited usefulness in running these regressions. And that's part of the reason why we ran an ensemble approach using 3 different models. Now, if we go to the last slide, what are the key takeaways and policy implications of this part of the work? Well, to summarize, there seems to be a slowing down in the rates. Growth will continue, though moderately. This is, of course, concerning. It's not something good, but even worse is the fact that there's growth in second-line therapies and third-line therapies, and in difficult-to-treat bacteria as well. And there's already high resistance in some countries in antibiotic bacteria, which we cannot forget in countries such as Greece, Italy, India, Romania, etc. Now, if we want to understand better why that is, we really need more and better data on all aspects that are related to AMR and resistance proportions. That, of course, means pushing ahead with initiatives like GLASS, the Global PPS, the EARSnet, among others, not only to collect data on resistance proportions and resistance rates, but also on the whole AMR ecosystem, meaning also the animal sector and the environment. And these, of course, will lead to better estimates and less uncertainty, which you have, I should say, for the first time in these estimates. I'll pass now to Dris to carry on with the presentation.
Okay, thanks, Tiago. Good afternoon, everyone. So Tiago provided us with comprehensive epidemiological analysis of antimicrobial resistance, and one of the highlights, as he mentioned, is certainly the fact that the growth in resistance that his analysis documented was driven by first and second line resistance to second and third line therapies. Now, as part of this study of ours, we were also interested in evaluating the economic and health burden of antimicrobial resistance. So to do that, we developed a health economic model. The model is a micro simulation, which we do a lot of here in the health division at the OECD, and it's designed to simulate the natural history of AMR and its impact on health and the economy. To be specific here, when we talk about economic analysis, we are interested only on the direct economic effect of AMR. In other words, we are only estimating the direct impact on healthcare expenditure. So our model is a micro simulation that runs between 2015 and 2050. We the number of countries included in this part of the analysis is slightly lower than what the 52 countries that Thiago mentioned. We're limiting this model is limited to the EU 28 countries, in addition to Norway, Iceland, the United States, Canada, and Australia. So this is our geographical scope. And what the model does, very briefly, is that we take samples from the population of each individual country. So these samples reflect the age and sex distribution of the population in each country, and we put them through a probability, transition probability tree, and people, in each sample, individuals are pushed through the different health states. That's why it's called a microsimulation, and they move between the different health states using transition probabilities that we derive from risk factors and mortality rates, etc., incidence of AMR. I'll talk about that a bit later in my presentation. So the model is based on a dynamic population. This means that we actually take into account the demographic evolution of the population in the model. So it's not a obviously static population. So the outcomes of the model are the number of deaths due to AMR, disability adjusted life years, health expenditure, and extra hospital days due to AMR. A couple of key assumptions. We assume in the model that there is no co-infections, that the subjects with a history of AMR, once they're recovered from their resistant infections, if they recover, well, they go back to the same risk of developing a resistant infection compared to someone with no previous history of a resistant infection. And also in the model, we assume that the risk of transmission is reflected by the incidence data that we put into the model. This means that we do not explicitly simulate the probability of transmission in the model. And finally, we assume that outside of the 8 bug-drug combinations that Thiago mentioned, we consider that all other resistant infections are in fact susceptible. So in other words, we assume that AMR is covered completely by the 8 bug-drug combinations that we selected. So I'll move straight to the results. So in terms of number of deaths, our model estimates that across the 33 countries included in the analysis, between 2015 and 2050, on average, 67,000 people die as a result of resistant infections each year. So again, very important differences between countries, with the largest burden in terms of mortality due to AMR experienced by, if we look at European countries, by Southern European countries, Italy, Greece, Portugal. The United States is up there in terms of absolute, in absolute terms. Obviously, the biggest countries have the highest number of deaths, with the United States experiencing around 30,000 deaths due to AMR each year. The EU 28 is EU countries, that estimate is around 36,000 deaths due to AMR each year. In terms of cumulative number of deaths between 2015 and 2050, our model estimates that if nothing is done, so this is the cost of inaction, if nothing is done, over the 35-year period, AMR would result in 2.4 million deaths across the countries included in this analysis. And again, with the largest countries experiencing the heaviest burden in terms of deaths, the United States, that's over 1 million deaths. Italy, almost 500,000 deaths over the modeling period. France is in 3rd position with 2,000 and 40,000 deaths approximately. Now, in terms of burden of disease expressed in DALYS, well, this reflects pretty much the distribution or the order shown for deaths due to AMR, Italy and Greece. So generally, Southern Europe experienced the heaviest burden of disease due to AMR. And just to, I won't go on for too long about the results of the business as usual scenario, because I want to spend a bit of time on the cost effectiveness analysis. But I just wanted to signal the publication of this recent paper that we co-authored with the ECDC. So this was published a couple of weeks ago, which very much is in line with the findings of our microsimulation, and that makes sense because the data we used in our microsimulation was provided by the ECDC. So we were very pleased to see that our results were actually validated by the formal assessment provided by the ECDC, and I'd like also to acknowledge their contribution to our work. So, and if you are interested in the epidemiological data that underpins our microsimulation, it's the details and the methodology of how those data were derived. I invite you to have a look at this paper. In terms of healthcare expenditure, so our modeling estimates that across the 33 countries included in our model, the cost of AMR is around $3.5 billion per year. So, and once more, we see that the same distribution, and it makes sense because the countries experiences the heaviest burden in terms of health impact due to AMR. It makes sense for them to also pay the highest price in terms of healthcare expenditure. Now, so far, we both Thiago and I, we talked about essentially about what the current situation is with regard to antimicrobial resistance in terms of epidemiology, health, and economic burden. One of the main objectives of this work was to actually go beyond this descriptive analysis and to propose potentially and investigate potential avenues to tackle antimicrobial resistance. So we started first by looking at what countries have in place in terms of policies to address antimicrobial resistance, and we did a review based on the categories defined by the WHO in terms of national AMR action plans, and this is the categorization we came up with. So we found that only 9 OECD countries have developed a national AMR action plan in line with what the WHO recommends. So that means a national AMR plan that is funded, that is in place, that is running, that involves all sectors, so health, human health sector, the livestock sector, and hopefully the environmental sector as well, and a plan that also has monitoring and evaluation mechanisms in place. So only 9 countries are in this situation. The vast majority of 9 OECD countries are in that situation. The vast majority of countries are either at a stage where they have a national AMR plan that is developed but not in place, or a national AMR plan developed but not fully rolled up across the country. 8 countries are in the process of developing their national AMR plan. AMR action plan, sorry. Okay, and then, so the question we're trying to address here is how to tackle antimicrobial resistance. And our approach was very pragmatic. we went from the evidence, we reviewed the literature to identify effective interventions, and we found plenty that we describe in our report. So these interventions are effective at the micro level. So which means there is plenty of evidence in the literature showing that there are interventions implemented at the hospital level or even at the ward level that are effective in reducing the level of antimicrobial resistance. So we in our report, in our modeling, we identified 6 interventions that have enough evidence backing them up and to include in our model. And these interventions are delayed prescription, mass media campaigns, stewardship programs, of course, enhanced environmental hygiene, which is basically improved hospital hygiene, improved hand hygiene, and the use of rapid diagnostic testing. We are fully aware that the other interventions might very well be effective. For example, there's a lot of hope around vaccines, etc. But we estimated that at this point in time, there isn't enough evidence yet to implement and roll up these interventions at national level. So we were very conservative in our approach. That's why we included these interventions. And what did we found? What did we find? Sorry, we found that all of the 6 interventions we selected are extremely effective. First of all, they're effective in preventing death due to AMR. For example, improved hand hygiene reduces, in our model, reduces the annual number of deaths by across the 33 countries included in the model by approximately 38,000 every year. Remember that our estimate of the number of deaths due to AMR in the base case scenario is 67,000 deaths per year. So it's more than halving the number of deaths due to AMR. We found similar results for stewardship program and enhanced environmental hygiene. Rapid diagnostic test reduces the number of deaths by around 15,000 each year, delayed prescription by 10,000, even mass media campaign, which was the least effective approach, prevented 5,000 deaths every year. So all 6 strategies are very effective. Just one point, one of the assumptions we used here in our modeling is we assumed that once these interventions rolled up at the national level, so scaled up to national level, we assumed that the adherence rate of the population targeted by this intervention is around 70%. So it's a very conservative number. We also assumed that governments who put in place these interventions commit to funding them throughout the 35-year modeling period. So we are fully aware of the complexity of putting an intervention in place and maintaining adherence, but we estimated that it's beyond the scope of this analysis to take into account basically the implementation problems associated with putting in place any public health strategy. In terms of healthcare expenditure, so the blue bars represent the implementation cost, and the red bars represent the savings generated by each strategy. And what we can see here is that all the strategies pretty much, the cost of implementation of all strategies is offset by the savings they generate. It's very clear for an intervention such as improved hand hygiene, which is very cheap to put in place, and it generates important savings. Stewardship program is fully, the implementation cost of stewardship program is fully offset by the savings it generates. Enhanced environmental hygiene is almost completely offset. Same thing with rapid diagnostic tests and delayed prescription and mass media campaigns. So in terms of cost effectiveness analysis, so we this is basically the part of the report that is that talks to the decision makers and the people who are supposed to fund this public health program that we are evaluating. And our aim here was to see whether it would make sense economically to invest in these interventions. And we conducted a standard cost effectiveness analysis. But we rapidly had a problem, because usually when you do cost effectiveness analysis, the main outcome is an evaluation of the incremental cost effectiveness ratio, right? And that is the cost that a decision maker has to pay to gain one additional unit of health outcome. So there's a threshold. Health economists have defined a threshold below which a health intervention or some new health technology is defined as cost effective. And usually that threshold is $50,000 per health unit. The health unit in our model here is the DALYS. So the standard cost effectiveness threshold is $50,000 per DALYS or QALYs. But we weren't able to calculate that because in a lot of countries, many of the countries included, the cost effectiveness ratio was negative, and you can't interpret a negative cost effectiveness ratio. So to allow us to compare the different countries, we decided to calculate the probability of across countries, the probability of cost effectiveness. And we defined 4 categories of cost effectiveness. So the blue represent an intervention that is cost saving. The green, or rather the red, represent an intervention that is cost effective, which means that an ISA below $50,000 per DALY gained. The green represents an intervention that has an ISA of above $50,000 per DALY gained. And the purple represents interventions that are inferior to the business as usual. And what we found is consistent with what I showed before, and the effect on mortality. Most of the interventions are cost saving, particularly those that are the hygiene-based interventions. Improved hand hygiene is almost 100%. The probability of implementing such a strategy is almost we're almost certain to generate net savings. Same thing with the late prescription, stewardship program, and rapid diagnostic test. The least performing intervention is, if I can say, is the mass media campaign, which has a probability of cost of producing saving of around 22%. It's still a very there's a 70 or 60% chance of implementing mass media campaign to be cost effective. Now, I presented the effect of individual interventions, but in real life, governments, we're not calling governments to choose one of these interventions. What would happen if we have a policy package, and we simulated that with a mixed policy package, including stewardship program, enhanced environmental hygiene, mass media campaigns, and rapid diagnostic tests. So combining all these interventions, and we found that such a package would lead to around 47,000 lives saved every year in OECD and EU countries, with the biggest effects in the biggest countries. And in terms of cost, such a mixed intervention package would reduce the health expenditure by around $3 per capita per year. And I leave the floor to Michele to conclude.
Thanks, Dries. Thanks, Tiago. So wrapping up, what are the main conclusions and policy implications of OECD work on antimicrobial resistance as part of the publication Stemming the Superbug Tide, just a few dollars more? First, antimicrobial resistance will keep increasing globally if we don't put in place effective and efficient, I would add, policy option to tackle this major public health challenge. The projected rise in resistance to second and third line antibiotic is particularly worrisome. Tiago showed the result that in OECD and G20 countries, a significant increase in this backup antibiotic will take place if we don't act now. Intervention to increase hygiene show the most positive effects, but do not address some of the key determinants of AMR. Working on hygiene doesn't have or has very small effects in terms of promoting prudent use of antibiotics. So this message was essentially to combine different types of interventions into packages. Single intervention are already cost-effective and very often cost-saving, but combining this intervention into packages will produce better results, and this package of intervention is an excellent investment for OECD countries and beyond. Now, OECD work on antimicrobial resistance doesn't stop with this publication. We'll keep working in this area for at least the next 3 to 4 years. In particular, early 2019, we start a new project to enlarge the scope and the breadth of the analysis that we have presented today. Our top priorities will be to include the evaluation of what are usually called indirect costs, essentially impact of antimicrobial resistance on the labor market, the broader economy. Carry out analysis in a One Health framework. We focused so far on antimicrobial resistance in humans, extending analysis to the livestock sector, agriculture, and environment. We plan to look at additional intervention, for example, vaccination, education policies, pay for performance schemes, and so on, and enlarge the scope, the geographical scope of our analysis to include even more countries and be more representative, in particular for when it comes to low and middle income countries. My very final slide is to present you our contacts. You will find results of this work at oe.cd/AMR 2019. More generally, work on public health and is at the second link. And you can also follow us on Twitter. And if you look at our public health webpage, you will find a link to other analysis on AMR and beyond the OECD carries out. I think I'll stop here. Mary Ellen, over to you for what concerns discussion and questions and answers.
Excellent. Thank you, Michele, Dries, and Tiago, for sharing your insights with us today and for leaving our network with a very clear package of priority action based on evidence, specifically those 4 areas of interventions to be implemented simultaneously across the healthcare sector. At this point, we'll open the floor to questions. We welcome questions and comments, your reflections, along with your name and affiliation, if possible. Now, to start, we have received a question regarding developing country settings. It says here, though this is not the focus of your report, based on this research focusing on OECD countries, what advice would you give to developing countries? Are there any important policies and regulations that you feel need to be set in place in order to benefit properly from the recommended mixed intervention package?
Thanks for the question. So this is Michele Cecchini, and I'll try to give a first answer. Then I invite also, of course, my colleagues to step in if they feel that more needs to be added. Well, yes, we didn't carry out a specific analysis for low and middle income settings. I think that one of the results that come out from our work, despite we focused on high income countries, is that there are very low hanging fruits which cost fairly little in a high income setting, but also most likely in low-income setting and that are likely to produce a significant result in terms of population health if they were to be translated into and implemented into low-income setting. And in particular, I'm referring to policies like enhancing hand washing. Policy that we have implemented looks very much like the WHO approach to increase hand washing among medical personnel in healthcare sector. This is an intervention that can be cheap and implementable also in more resource-constrained setting. A second one is utilization of mass media campaigns. Now, from previous experience, not necessarily in AMR, but intervention that increase awareness in the population tend to maintain a similar level of effectiveness across different settings, independently from the income of the country, and produce similar results in low and middle income setting with lower implementation costs. A third one may be in terms of delayed prescription, which again has a fairly low implementation cost. This is just to give you some example. There may be further action that can be implemented in low and middle income setting that would probably produce excellent results. Not to forget that when it comes to low and middle income countries, a key issue that we didn't address in this piece of work is access to effective and high quality antibiotics.
Thank you. Any other comments from the other speakers?
Tiago here. I would just add a note on data, if I could put my data hat on. Naturally, developing countries will face more difficulties in collecting and setting up surveillance networks, not only in terms of resistance, drug resistance, but also in other areas that matter, such as the animal sector and environment and antimicrobial consumption as well. But that's really very important. And in the publication, you'll find a box that discusses the challenges of defining and measuring drug resistance. And it's very important that initiatives like GLASS really push ahead because they standardize measurement. And these issues, it's not so much that certain countries don't have data, but they maybe don't have data that is comparable. And so that's one issue that really developing countries should tackle and keep in mind. It's not only about the policies to target, but also measuring. That's it from me.
Very, very quick comment. So I think Michele summed up pretty much what our perspective when it comes to low and middle income countries. Just wanted to highlight the fact that in the next iteration of the cost effectiveness analysis, we are very much keen and we'll try as much as possible to expand the geographical scope of our analysis to try to include some of the low and middle income countries. Of course, as Tiago mentioned, there's the issue of data availability, but we are already trying to address that and identify good data sources. In terms of the interventions to be modeled, obviously a lot of them will be some of the interventions will be completely different and specific to low and middle income country context. Things like, as Michele mentioned, access to good quality antimicrobials and just plain access. There's still the problem of access to antimicrobials. So we are thinking about this, and we'll hopefully in a couple of years we'll be able to report on that.
Excellent. Thank you for that. We have a question here asking for some clarification. It's a question coming from China. Perhaps you could give a bit more explanation and examples of the rapid diagnostic test that you've referred to in the presentation.
So yes, so the rapid diagnostic test, it consists of basically providing, so by the way, I should specify, in our modeling, the rapid diagnostic test targets GP practice. So the use of rapid diagnostic tests in our analysis is only for community infections. And what these tests allow is that when you go to see your GP, and the GP suspects an infection, instead of prescribing an antibiotic treatment, well, they actually conduct this test beforehand. And these tests are particularly handy because they significantly reduce the time between the time for the analysis. So from several days to actually, take a swab or blood sample and do the culture, etc., to a couple of hours, where based on a quick blood sample in a few hours, you have the results of whether patient needs indeed antibiotics or whether they don't. So instead of, it basically makes the decision of prescribing antibiotics easier, in the sense that is, you have a test that provides you with the evidence and the justification to prescribe antibiotics.
Just to add on this, in the specific, the way in which we model the intervention looks like a lot a C-reactive protein test. And that's the type of test that we modeled.
I do want to be conscious of our timing. We just have a few minutes left. I do invite others to send the questions that weren't addressed via email, and we will do our best to address those at a later time. You can send your questions over to lhsn@imperial.ac.uk. But for the time being, we usually invite all of our speakers to leave any remaining last points or pieces of advice to our audience before wrapping up.
Sure, thanks. I'll start. My wrap-up and my take-home message is investing in tackling antimicrobial resistance is very effective, is very cost-effective, most often cost-saving. There is no excuse for countries not to invest more in tackling AMR.
Excellent.
Dries here, so I'll have a final word as well. Wash your hands.
Tiago here. I'll just emphasize again the importance of collecting data on this topic, and that's it. That's it for me.
Excellent. Thank you so much for your insight. Thank you again to our speakers and to our audience for joining. As a reminder, the recording for this webinar will be available on our website at www.leadinghealthsystemsnetwork.org. New webinar announcements are posted on LHSN's social media account, so do please feel to follow us on LinkedIn, Twitter, and YouTube for that information, or just sign up for the LHSN newsletter on our webpage. I know that on our webinar archive, we will have a link to the report that's been mentioned in this webinar presentation, but I'm sure that on the OECD webpage, you'll also find a link to that as well. Again, to wrap up, I'd also like to highlight some of the network's latest works. On the 13th of November, the LHSN released its report on antimicrobial stewardship, which presented evidence-based and globally applicable tool, the checklist for hospital antimicrobial stewardship programming called CHAST, and it supports health providers across resource levels to address AMR. CHAPS contains core elements for antimicrobial stewardship programs, and the report itself offers comparative health systems insight through an in-depth look at checklist responses from 12 LHSN institutional members on their hospital antimicrobial stewardship programs. As these programs, as their implementation often depend on complex contextual factors specific to each health provider, the report provides a summary of potential strategies for overcoming 6 common barriers. Again, it's been a pleasure to host this session. During the research for this particular report, it was obvious that there isn't enough being done, enough analysis that is evidence-based on cost-effective interventions. So I think this is a huge contribution to the AMS and AMR agenda. So thank you again. And with that, we will conclude our session. On behalf of LHSN, we wish you a great day and hope you'll stay tuned for our next event.
Thank you very much to Mary-Helen and to all the person that listened to us. It was our pleasure. Goodbye to everybody.